everyone. My name is Jess Nicholas, and we are back with another dentist interview in our Roundtable Discussion Series. And today I am here with Dr. Stephen Brown, who is a periodontist in Philadelphia, Pennsylvania. And I'm also here with Dr. Joe Nemeth, who is also a periodontist in Southfield, Michigan. And today our discussion is going to center around gum recession, which is a condition that happens when the gum tissue surrounding the teeth draws back or wears away. This is often caused by gum disease, which can lead to other dental issues. Our guests today have many years of experience with this condition, so we're very excited to hear from them and hear how this can be treated. So without further ado, the first question is for Dr. Brown. And the question is, what is gum recession and what causes or contributes to it?
Well, gum recession, as you mentioned before, is where the gum sort of moves down from where it was when you were younger down the tooth. The part of the tooth that we see in the mouth is the enamel or the crown of the tooth, and the gum should be like a turtleneck sweater collar at that level. But when it moves down, that's what recession is. And it's caused by a number of different things. Periodontal disease, gum disease, is one of the biggest reasons. Overly aggressive oral hygiene, brushing too hard, can be a contributing factor. Orthodontics as a kid or as an adult can be a factor, and we can talk about how that works. And the way teeth erupt, sometimes they erupt in such a way that the gum is not at the normal level. Also, genetics, aging, all of those things are factors.
Okay. Dr. Nemeth, how prevalent is gum recession?
I would have to say, from what I've seen, probably 75 to 80% the population has some degree of gum recession, which tends to increase as we get older, because gum recession is usually slowly progressive. So it may start in your teenage years, not be particularly noticeable, but as one gets older, that recession tends to progress and proceed. In fact, there's a term for that called long in the tooth. So if someone is long in the tooth, it really means they're old. Oh, they're long in the tooth. That's an old person. Well, where did long in the tooth come from? Long in the tooth came from gum recession because it proceeds so slowly that in many cases, it isn't until one is really older that the gum recession is really apparent and possibly even disfiguring and possibly putting a tooth at risk of being lost. So, that's some of the points about gum recession. It's very interesting. Usually it's painless. People don't normally notice it. Sometimes the teeth become sensitive to cold because the roots are sensitive. The enamel isn't, but the roots are once they're exposed. Sometimes decay can start on the roots also when the root is exposed. And of course, when the gum tissue recedes, the underlying bone recedes with it. You can't have bone unless it's covered by gum. And when that gum is gone, the bone is gone. And when the bone is gone, the support starts to disappear. And if it becomes serious enough, you lose enough bone that, you bite down and all of a sudden you got a tooth in your hand.
Exactly. Dr. Brown, can you elaborate a little bit on that? Like some of the symptoms and dangers of not treating gum recession?
Yeah. As Joe mentioned, probably one of the most frequent reasons why people come in is because their teeth are sensitive. They're sensitive to thermal changes, more often, as he said, to cold, and that can be extremely uncomfortable. And people don't know what the reason is that they have this. That's what brings them into the dentist. Decay in the root of a tooth. And by the way, when there is gum recession and the root is not covered by enamel, like the part that you see in the mouth, that makes the tooth much more vulnerable to decay. And when you have that kind of decay, it affects the nerve of the tooth, which in turn is the reason why we have the sensitivity. In addition, there's changes in cosmetics, frankly, from recession. Oftentimes, the color of the teeth changes, the appearance, and that also is what brings patients in. They're smiling and they see all of a sudden something dark or brown, and they don't know why that is, and they want to get rid of it.
Okay. Dr. Nemeth, can you please describe the traditional methods of treating recession?
Well, the traditional method, and which is still practiced, is by taking a gum graft from the palate, from the roof of the mouth, cutting out gum tissue from the roof of the mouth and taking that gum tissue and putting it over the area of where the gum is receded. So one lifts up the gum, you lay a flap where the gum is receded, you cut out a chunk of tissue from the palate, you put that tissue over the area of recession. Then you bring the gum down, that flap of gum, over the graft that you've taken from the palate, sew it into place, and let it heal for a couple of weeks. That's the method that, let's call it traditional. It's been used for many, many years. It's still recommended by lots of periodontists. Is it effective? I think it can be effective. Does it have drawbacks? Oh my God, does it have drawbacks? The drawbacks are, I'll let Dr. Brown talk about the drawbacks because they are vast.
Yeah. When I think back to the way in which we were doing it some years ago, I cringe, because what happens is, first of all, when you do it the traditional way, the way that Dr. Nemeth was mentioning, there are two wounds. That in itself makes it more difficult. They take a piece of tissue from the palate, so there's a wound there, and they have to make a wound to create a receptor site for the donor tissue that's taken from the palate. Quite frankly, oftentimes I used to tell patients, it's going to just be like a pizza burn on the palate. Well, I can tell you it's a pizza burn times 20. And patients remember that. And it's something that they are concerned about because they have all of this discomfort and it lasts a long time. So anything that we can do to become more minimally invasive is what most of us who are looking for alternatives to that method, because as Joe said, the vast majority of our colleagues are still doing it the same way. And in the schools in which both of us have taught, they're still teaching it that way as well. Some of the newer methods are not being taught at all.
Dr. Nemeth, can you talk a little bit about the minimally invasive pinhole technique?
And that's basically all that I do now. I almost never do the traditional, let's call it traditional technique. First of all, when you do the traditional technique, you can only do a certain number of teeth. So you're limited simply by the amount of tissue that's available, number one. And that is not the case with the pinhole method. And that's the newer technique. That's the technique that I use all the time. Dr. Brown uses it. And we were among the very first to be trained in that technique by Dr. Chow. And we've also gotten further training. So we are now secondarily qualified as well. At any rate, with the newer technique, the pinhole technique, there's no limit how many teeth you can do. You can do one tooth, you can do 7 teeth, you can do 20 teeth, you can do 32 teeth. And there have been mouths where patients come in, they've got recession throughout their mouth. You want to do the old-fashioned technique, not only is it painful, but they have to go through it 3 or 4 times. It's almost unconscionable. So the newer technique is usually pretty painless, actually, because you're not cutting tissue out of the palate. That's really the most painful part. you're actually making a little small incision or a little pinhole under the area of recession, loosening the gum tissue. When the gum tissue is very, very loose and separated from the bone, that's loose enough then to bring over the roots of the teeth. We bring it over the roots of the teeth, and then we put a material like a collagen through that little pinhole to thicken the gum tissue and hold it in place. And the only thing is that the patient needs to be careful for a couple of weeks while it's healing. But usually pain is completely absent or certainly minimal in that minimally invasive technique. It's totally great. That's all I can say.
Let me pick up on what Joe was saying. He mentioned that you would have to do multiple procedures if the patient had a lot of recession. The ability to do, I used to be able to do no more than maybe 2 to 3 teeth at a time. So if you think that we have 12 to 14 teeth in each jaw, let's assume that we were doing that. That would mean multiple procedures over multiple months, because you got to go back to the palate to get more tissue. It has to heal. Now, most people who come in, I can do from one side of their mouth to the other on the top, let's say, in under 2 hours. Before, it was an hour to an hour and a half for each procedure. So by being able to do it quickly like that, and as Joe also said, these little tiny pinholes that are made with a little tiny needle to insert the instruments, we see our patients at 24 hours. And within 24 hours, those pinholes are all healed. So it's completely different. The amount of swelling is different. When people swell, that adds to the amount of discomfort that they receive. So that's another reason why. And patients are absolutely in awe of what they see at the end of the procedure, because we can lift their lips just slightly, let them look, and it's amazing the responses that people have to this.
Dr. Nemeth, can you talk more about the recovery process, like a long term, not just 24 hours later, but down the road?
Well, generally, as far as the recovery process is concerned, we will generally tell the patients no brushing for 2 weeks, no chewing of any significance, no hard foods, not even kind of soft foods, but no chewing, nothing that requires any chewing, again, for 2 weeks, because we do not want that tissue disturbed during the healing process. Once that 2 weeks is over, and sometimes we do use sutures or stitches, depending on the condition, then any sutures or stitches, at least in our office, are removed. We then start the patient on their toothbrushing, gently at first. We see them again a couple of weeks later and make sure everything is coming along well. Go over the toothbrushing again so that they can get into their normal toothbrushing habit. And during that 2-week initial time, we give them a rinse, which is an antibacterial rinse, so that there's no chance of infection, because patients say, oh, I can't brush my teeth for 2 weeks. Yeah, but no, you'll be fine. We're going to give you something to rinse with that will take care of any problem. Then after 2 weeks, as I said, they start brushing. We go over home care, and we anticipate this lasting a lifetime. There's no reason why it shouldn't. As long as the patient doesn't abuse their mouth afterward, I think the chances of it never having to be redone and lasting a lifetime are excellent. So long-term results, as far as I'm concerned, are terrific. Now, if a patient abuses of their mouth, they start scrubbing really hard, or have some other work done, maybe then have braces or Invisalign, that can change things. But normally, this should be a lifetime procedure. At least that's the way I feel about it.
Dr. Brown, who is a candidate for this procedure and who is not a candidate?
Well, almost everybody in my experience that has recession can be a candidate for this procedure. if people have certain medical issues that would preclude doing surgery, then they may not be a candidate. But healthy patients who are not on blood thinners, for instance, who have recession, almost invariably can have this procedure done. And, I think back to Dr. Chow, who Joe mentioned earlier, who was the developer of this technique, published his first paper in 2012. Joe and I and our colleague, Dr. McCauley, took his course the next year. And I've never looked back. The results are so astounding and so pleasing and so lacking in the discomfort that people have come to expect, that people come asking about having this procedure because they know there's only a few of us who are doing it. And so this has been a wonderful practice builder. And the fact that they come back the next day and they're really quite amazed to see what the difference is in 24 hours. So I am very high on this procedure. As Joe mentioned earlier, we went back and took the advanced course with Dr. Chow, and we are certified in that regard. And in addition, I've had the pleasure of being asked by Dr. Chow to lecture to his classes, and I've been back a couple of times. Interestingly, I don't give the same lectures to the classes at the dental schools that I teach at because they have not accepted this technique as being routine as we have.
Dr. Nemeth, why do you think this technique has not been more globally adopted by periodontists?
It's being more and more adopted all the time by periodontists as well as general dentists. Sometimes a technique just takes a while to catch on. When it comes to healthcare, new techniques have to be around for a while frequently to catch on. And also there's a learning curve. So some people may take the course and learn it, but if they do it and they're frustrated a couple of times, they're going to give it up, and they'll say that to their fellow periodontists, and so discourage their fellow periodontists. And in the dental schools, they still teach the old-fashioned method for the most part, and it's archaic. And sometimes archaic things just take a while before the fact that they are archaic is realized. So it's catching on slowly. There are people taking courses all the time, but there is a learning curve. I can do so much more and so much more effectively with the pinhole technique now than I could when I first learned it, because you're gonna run into some problems. There may be a failure here or there, and then you'll learn something from that. So the longer you do it, the better you get. And it's a never-ending learning curve. And it's fascinating. And things that I couldn't do before with traditional method, or I thought I couldn't do with a pinhole, all of a sudden, I realized they are doable. I've never seen a case that the traditional method was recommended where pinhole could not be done. And in fact, I've had patients with horror stories of the traditional method. They had the traditional method, chunk of gum taken out of the palate. It was for them experience that they ever want to experience again. And so we see some of those also. But at any rate, I think it's going to spread more and more, and I think it's going to be great for dentistry, and it's really going to be great for the general public. It's, as far as I'm concerned, it's really the only way to go in almost every case.
Dr. Brown, anything to add?
Yes, a little bit. I mean, what Joe explained is absolutely correct. It's the experience that all of us have had, and I really respect him for the innovations that he's made in this area. However, you asked before why this hasn't been more broadly accepted. And I think, in a word, we doctors, and I mean all of us, are very slow to make changes. We do what we know, what we've been taught, and we tend to not get far afield from that. And this was a completely revolutionary way of doing things. And as Joe said, I suspect over the next several years that it will be more universally accepted. Hopefully, some of the dental schools will start to give courses or at least teach the residents how to do it. Because once they do it, they're not going to ever turn back. And I can attest to the same thing that Joe said regarding the patient's response. Some of these patients who come have found out that we're doing this technique. They've had it done the other way before, maybe in a different part of their mouth. And they come in and they tell us literally horror stories. And when they come in the following day, at least in our practice, I mean, they're all smiles. There's no swelling to speak of. There's minimal amount of discomfort because you have not disrupted the tissues that much. You're operating through this little tiny pinhole. And that in itself makes for a much better outcome initially and longer term.
Dr. Nemeth, do you have anything else you would like to share with our audience about gum recession or the pinhole technique?
It seems to me we've covered really all of the most important major points. I will say one thing. I would say probably 75 to 80% of the patients that I see with recession have had orthodontic treatment or have had Invisalign, because when those teeth are moved, it thins out the gum, it thins out the bone, and makes that tissue much more susceptible to recession. Sometimes it recedes right away. Sometimes that recession doesn't occur for 20 years later. But in the vast majority of cases that I've seen, orthodontic movement has occurred and is a major contributing factor, as Steve said, and also genetics, very important. You inherit thin gum tissue. Thin gum tissue recedes much more easily. You brush too hard, don't brush too hard. People who are clean freaks are the most likely people to have gum recession because they're scrubbing their teeth too often, too hard, with too hard a brush sometimes. So, and age, of course, and gum recession tends to continue on unless something's been done to stop it. Studies show that it doesn't stop. It keeps getting worse and worse and worse. And therefore, if you don't want to lose bone and you want to save your teeth and you don't want any more recession, you need to get some thick, healthy gum tissue to stop what's going on, or you are at risk. And those are just some of the thoughts that I have.
Dr. Brown, anything to add?
I would just like to say that if you have recession, look for somebody who is doing this procedure, because the differences in what you're going to experience in order to correct the problem, and I agree with Joe completely that an inordinate number of the patients who come to see us have been orthodontic patients. And when the teeth are moved, they become prominent, sort of like a washboard, and there isn't a lot of good bone covering over it or soft tissue, which is why we get the recession. But look for somebody who's doing this procedure, go in, have a consultation, find out what can be done for them, because we can do it quickly and non-invasively, minimally invasively, with minimal discomfort and maximal result. And you see the result immediately. The thing that tickles me is when we do the reveal. We'll show that to the patient just after they're done. Gently lift their lips and they go, like that is not at all unusual. And in a dental office, we don't see that often, certainly not in the periodontal office. So it gives me a great deal of gratification to be able to do that for folks.
Yes. Okay. Well, thank you both. This has been extremely informative. We've learned so much about gum recession, and the unique technique that you guys use is not the procedure of the past. Obviously, sounds painless. You have results pretty much instantly or within 24 hours. So if this sounds like something that you might need for your dental health, we will put Dr. Nemeth and Dr. Brown's information, phone number, and website in the description. Thank you so much, Dr. Brown, Dr. Nemeth, for your time and expertise in the field. And thank you for watching, and have a great day.